With more than 6,000 small and microcap companies listed, if you're looking for the next Apple at the earliest stage, then Channel Check truly is the orchard. The listed companies support Channel Check, so it's free for you, the potential investor, to gain access to institutional quality research from FINRA licensed analysts, advanced market data, industry reports, news, and a growing catalog of videos and webcasts. Make sure to subscribe to our YouTube channel and register for Channel Check so you're always up to date on what's going on at the small and microcap data place. Welcome to New Methods in Pain Management, a NobleCon online investor event presented by Channel Check and Noble Capital Markets. Noble is an SEC-registered, FINRA-licensed broker-dealer and the source of the equity research available on Channel Check. This presentation features MedX Health Corp, OTC ticker symbol MDXHF, TSXV ticker symbol MDX. Following a brief overview presentation from President of Dermatology Services Mike Druhan, Noble Research Analyst Gregory Aurand will moderate a Q&A session. And with that, I am pleased to present Mike Druhan.
Hi, thank you for being here today. Really appreciate everyone and having the opportunity to present MedX's technology and where we sit in the market. I'll start with the first slide by saying a fairly declarative statement that MedX is actually the leader in Tele-Dermatology. And I'll get a little bit to that in a minute. Standard confidentiality and forward-looking statements apply. And a little bit about Tele-Dermatology versus telehealth. So with the advent of COVID, what we start to see was a fairly large increase in a need to get to doctors and that without risking the healthcare profession. So telehealth took off. We saw a lot of companies in the US, companies like Teladoc, Canada, companies like Maple, and all of those companies had already had experience in the space, but they gave a clear ability for patients to be able to access care from their GPs and then get redirected to specialists. Tele-dermatology is really a subset of telemedicine, which allows you to specifically get to a dermatologist for any kind of skin infliction. We specifically do something a little different than some of the other telehealth companies in that skin cancer, the pigmented lesions that cause, death potentially, is one of the areas that we can deal with, differentiated from other companies. So skin cancer is a major public health problem. There's about 60,000 people die every year with skin cancer. It's growing quite dramatically as the population becomes older, a lot more leisure time outside. And about every hour in the United States, a person dies from melanoma. So areas of the world here in red are quite epidemic in skin cancer. And so it is a very exciting target for us to focus on. The Canadian model is a little bit of a unique model in that we only have 537 dermatologists in Canada serving 37 million people. And so the Canadian market is a very difficult market to get in to see a dermatologist. And with COVID, that has extended that time dramatically. So in Canada, if you're going through our referral system, up here, it takes between 5 and 18 months, and I want you to keep that number in your head in Canada, to get in and see a dermatologist. And that's way too long because if you have a melanoma and it's evolving, there's a good chance you don't get to the dermatologist on time. So clearly being able to get triaging and getting people that need to see a dermatologist quickly is a very important part of what those functions that we offer. So I said earlier in our slide presentation that we're the leaders in teledermatology. And to make that kind of claim, be a declarative, here's what it means to actually be a leader in teledermatology. These are the functional sides of what you have to offer. You have to have advanced image capture system. And by that, I mean technology that will allow you to take a perfect image of a suspicious molar lesion and be able to make sure that that molar lesion image can be transported successfully over to a dermatologist for assessment. Currently, about 42% of the images that are sent across using telehealth systems are unreadable by dermatologists. And so that's not really helping the system deal with the problem. So there is a unique set of image capture that you need to have rather than cell phones and that in order to do this task. You have to have a patient management system that allows you to take the patient's image and attach it to the molar lesion, to that patient's information, and you have to have a navigator system. And the navigator system allows you to, if in fact the patient's molar lesion is a suspicious molar lesion that needs a biopsy, that you can make sure that the patient's follow-on care was there, what they call circle of care. And this is a big one. In order to be a enterprise scale telemedicine, teledermatology company, you have to have what they call SOC 2 level security around the patient's information. So normal privacy is great to have the HIPAA and PIPTA and those sorts of GDPR security systems for protecting the patient, but they don't protect you from threatware and so ransomware. So one of the things that we have done with our security system is we've got SOC 2 level security, which means that we're at the highest level of security, so that if we're going into large scale pharmacies and enterprise sized companies, that they know that we're not going to risk their brand because we're secure with the systems that we have in place. You have to have the ability to store that patient's information for up to 10 years and be able to pull it back up. So if you go in and rescan a patient later, we have all that capability. And of course, you have to have FDA, CE, and Health Canada. We're currently 35 countries that we're able to sell our telemedicine system into. Peer-reviewed research to validate your technology, and you should have an AI strategy that's real-world based, and I'll speak about that a little further along in the presentation. So how does it work? So we provide to a clinic or a pharmacy or a health insurer or health provider, we provide the camera, a scanner, and a HD clinical camera, along with our Cystoscope, which is our contact dermoscopy. It attaches into a standard computer, just has to be Chrome based and run on a Chrome system. And we have the preloaded in there, the patient management system. So we can take the image, put it into the patient's file, send it securely across the internet. The dermatologist receives a notification that they've got a patient's molar lesion to deal with. They can take the molar lesion, they can assess it, and then render an assessment about, this is fine, it's nothing to be concerned about, we want to follow it, or you need to come in, we need to have a biopsy done on this. We've got a senior management team. We've recently added to the senior management team. We just brought in Sylvain Dejanes. Sylvain has 34 years working experience in the healthcare industry, exemplary background in building and leveraging networks and companies. He's visionary. I'm honored to work with Sylvain. He has been a great addition, has done a lot to bring in some strategic thinking to the company, and he has huge access to the pharmacology industry as well, and that's another big part of our offering as we move down the road. We have a medical advisory board, and this is just a bit of our medical advisory board. In Canada, Dr. Trevor Champagne, highly qualified dermatologist specializing in teledermatology. And the other big add with Trevor to our team is that Trevor has a background in computer science and mathematics, which allows him to do and get really functional artificial intelligence up and running on our system. And I will say that we have a much different strategy on AI, and I'll speak about that a little further along. And people like Dr. Dan Siegel, who's a former president of the American Academy of Dermatology in the United States, he has been guiding us all the way along with our technology and what we should be doing. So we take a lot into our dermatological community and take in their feedback to make the best system available for their use. So what do we do different than our other stuff on the market? So on the very top slide here in the top left corner, this is called a dermatoscope or a dermascope. This is what your dermatologist would use if you had a suspicious molar lesion. It's got a polarized lens, it's got a light source, and the dermatologist can look through it, and they get to look at the structure below the skin a little bit. They can see here on the image to the right, there's a blue-gray veil there. This is a clear melanoma. So the dermatologist, if you were in his office, would have that biopsied right away. Once you start using the other technologies, cameras and videos and cellular phones, the images get quite granular because a lot of the times they can't send the size of the image across the internet that you need. And you get these, when it arrives at the dermatologist, it doesn't have a lot of features. And because people are taking images with phones, they're quite blurry because the people's hands are moving, they're not focusing quick enough, they've got too much light coming in. So what you end up is a very poor picture. And as I said earlier, 42% of those current images that are sent across the internet cannot be assessed. So that really doesn't lend itself to the adoption curve of teledermatology. Our technology is extremely different in terms of image quality and image capture. It is the best in the world right now. So here's a typical story of one of our patients. This was a young lady. She had this lesion on her shoulder. You can see that in this image, quite an what we call an ugly duckling, and it's a pretty self-evident that that's suspicious. We provide a clinical view to the dermatologist, so the dermatologist can see this. It breaks all the barriers on evaluation. It's asymmetrical, it's colored different, it's got borders that are irregular, it's evolved, it's elevated. That's something that is a concern. This particular mole was missed 3 times by GPs. And until I actually saw this lady, and I was at a golf course, and I said, "Do you mind if I scan this?" We ended up scanning her, and it turns out it was a melanoma. The other thing our technology does is it allows us to look below the skin, and we can see below the skin other disorganizational features. So we can see things like the melanin view, and in the blood view, we can see structures that shouldn't be there. So a dermatologist looking at this would immediately know that's a melanoma. This particular patient, this was a Friday at 10 a.m. that this was scanned. That was Monday at 8:30 in the morning. This was removed. It was in situ, so that means it didn't get into her bloodstream, and so she's going to have a very high percentage outcome of having a successful life and go on. We also catch things like this. Now, this is the most dangerous of melanomas. This is called a nodular melanoma. And this melanoma can take your life in 8 to 11 weeks. They grow very quickly and they go vertical very quickly, and they get into the bloodstream or lymphatic system, and they spread very quickly. This is a very aggressive cancer. This one, if you looked at just the contact dermoscopy image on it, it looks a little bit bad because it's a little irregular. It's quite dark, and there's a little bit of what they call ethereal blush off to the side. But if you start to look through below the skin, you get to see all of these telltale traits. Heavy dermal melanin concentration. You get to see in the collagen view some push down in the collagen, which is very 2 millimeters below the skin. So our imaging capture technology allows us to do pigmented lesions perfectly. Cost to the healthcare system. If we catch a melanoma at stage 1, the 5-year survival rate for the patient's 97%. The cost to the healthcare system is about $2,400. If that progresses to a stage 4 melanoma, and that can happen in 8 months to 11 months in the case of the first one you saw, or 8 months and 11 weeks in the second one, or sorry, 8 weeks to 11 weeks in the second one you saw, then your survival rate drops to about 20%, and you get on some very expensive drugs, what they call PD-1 inhibitors, and to keep you alive for those 5 years, it costs the healthcare system about $1 million. So clearly, like all cancers, catch them early, much better survival rates. And then we also have a secondary addition to our offering, which is a high-definition clinical camera. That allows us to do with the other things. I mean, the skin's the biggest organ on the body, and this allows us to deal with rosacea and acne, psoriasis, and also things like tropical rashes and skin parasites, and stuff that you get in the hotter climates. So this all collects up into the patient management system. So in the patient management system, we know everything about you. And this is very good for metadata that we're able to collect on the data, collect on the various images that we have, and then we're able to sell those to companies that are in the pharmacology business that are looking to do research. So, this one here, we collect on the patient. We know where they scan them. They know everything about them. And in this one this was actually, I've added, obviously, this is fictitious, but I did add the proper assessment that was given by the dermatologist on that nodular melanoma. So the dermatologist read it, said, this is a nodular melanoma, and basically said, reviewing the history and its comments, it appears this is a new lesion. It is clearly pigmented, and its appearance is non-reassuring. I am concerned. I think this should be exercised relatively rapidly. If you have difficulty arranging a local, because this patient was away, a local, and prefer to come and see me, simply message me and I'll make sure I see you in my office. And that patient, we got that, that mole was removed immediately. And in fact, it was a nodular melanoma. So happy outcome for the patient, and that's what our patient management system looks like. So we really service right now two vertical markets, and we'll be moving on to a third here shortly. With our Cioscope, which is the high-end the high-end camera, the scanner, we're able to do things that are all cellular, and that includes basal cells and squamous cells rather, and melanomas. And that's for the stuff, the cellular stuff. And we have a patient pathway there. It's already working and up and running. We have the ability to monetize that using biopsies and monitoring it. There's money into pharmacology, data mining, decision support. So all of that goes in, comes with the hardware, goes into pharma. There's medical clinics and places we can place that. And then accompanying that is for the inflammatory inflictions that you have on the skin, acne, rosacea, all of those things. So those two are there. And the third stool, or the third leg we're putting on the stool, and we'll be introducing shortly, is wound management. So imagine with COVID, amount of people in nursing homes that were in beds much more time than they should have been. They end up with pressure ulcers and diabetic ulcers and that. Now we have the ability to go into and put it into a crash cart, have all of that available imaging there, and straight to wound management specialists to deal with that. And that'll be another piece we'll introduce here probably first quarter of 2022. So we have on the AI, one of the things where we think the world's failing on AI is they're following this idea that we can take pictures with your phone and then the AI will be able to identify if it's a melanoma and sort of bypass the dermatologist and just let the AI do it coming out of the library. We think this is a very false statement. We think it's a false premise. We think there's no validity in having decision-making, ultimate decision-making AI. That's not our position. We have real world large inventory in our library. What we do with our AI is let's deal with the big real world issue. 42% of the images that get sent to dermatologists are unreadable. Our belief system is with our AI, and we know this, we have about a 1% deficiency rate on our images now. We can get that down to 0. And that really increases our adoption and uptake from dermatologists willing to read images because they're not going to be wasting their time. So it's a yield management tool to the dermatologist. And I'll speak about that a little bit later. The whole piece about us with AI is that we don't do anything on the artificial intelligence side that isn't monetized or doesn't make it easier or adoptive for our technology. So we do believe 100% that the dermatologists have been trained to read this. Dermatologists are in the pathway that they can get the patient in for biopsies. If it needs oncology, they can do that. They should be the end. So every scan that we do is read by a dermatologist. And our model is this. We've got a hardware model in there, which is a lease model really, and it works out to about $185 a month USD for you to have our technology sitting inside one of your clinics or a pharmacy. That's what we pay on the lease subscription side. And then we take a click fee every time we're taking a patient's information and sending it across the internet. And that ranges depending on where we are and depending on if it's a private pay or public pay. And it can be as high as $50, but typically it'll run somewhere between $10 and $20 US per click charge. So in summary, MedX is sitting here with a completely FDA approved, CE approved, Health Canada approved hardware, software. DermSecure is the platform, and we are fully commercialized now. We are up and running. We are a SaaS model where we have recurring revenue. We have a large order that we have in the Brazil that we're just working through right now. We will plan to expand. We will go into Mexico, Italy shortly. We're in the USA. We will be in the UK shortly, Switzerland, Canada, and Middle East in 2021, 2022. We have added the additional HD camera that's up and being pushed into our system now, and that'll add additional recurring revenue because as much as there's pigmented lesions, there's a lot more revenue coming from other afflictions like acne and rosacea and that. So expect to have a much higher revenue count from the clinical camera. But we do have the ability to do the pigmented lesions where others can't do that. So we'll start to implement our AI initiatives in the Q3, Q4 on our platform. We're doing that already, making sure that the images quality that we send over to dermatologists is 100% readable so that we get a great satisfaction from our dermatological community. And the object is to have a significant number of pilots up and running in Q4 and Q1. So what we're going to do for the financial community as guidance is the ability to get pilots up and running and allowing our shareholders to know this pilot will run for 3 months or this pilot will run for 6 months. And we have clear objectives on the outcome of the pilots. And if those pilot objectives are met, we expect a conversion into a rollout. And here's how large the rollout can come. So the shareholders will have some kind of context now about, okay, here's how many pilots they have, here's what their conversion ratio is, and they'll be able to take a look at how many locations that we get, and then about how many scans we do. And to give you some sort of guidance on that, in the Netherlands, we have right now 4 of our scopes are up and running, but we're moving to 8 here momentarily. But of the 4 scopes that have been tried in the Netherlands now, we've done over 4,000 scans since the beginning of the year till now, and we've caught 200 melanomas. So it's getting great success and great reviews in the Netherlands market, and they're going up to 11 and then to 20 locations. So we expect continued revenue. So people will be able to start to read, shareholders will start to be able to read what our revenue run will look like once we start publishing those numbers, and we're working with the financial team to put that together now. And I think I'll just go one more slide. So MedX has a lot of shares outstanding, and that's because we've done a number of financings along the way. But I would point out that we've got just a very small market cap. I mean, fully diluted market cap of 36 million. Comps in our space have up to $1 billion in sort of people trying to treat the same sort of function as us. So we have got a reasonably small market cap. We've got insiders, 16% of the company, institutional investors, about 15%, and retail brokers, about 16% on ownership that we've identified. I think as we start to pivot into a revenue generating and people start to see, I think we'll start to attract a lot more micro cap and institutional investors. And I can say on behalf of ourselves and the team, everybody in our team is driven, and we exist to save lives, and we get to do that every day, and it's a real honor. I thank you for your time.
Mike, thank you very much for that presentation. It was illuminating, to say the least. I have a couple of follow-up questions, if you don't mind, in terms of just trying to get a little bit more deeper into what you covered. In terms of the image capture technology, how are you doing that compared to competition? And are there any barriers to prevent other people from duplicating what you're doing?
Yeah, great, Greg. A great question. So the MedX technology, the Cioscope, which is the image capture, uses light spectrophotometry. And there was about $11 million on R&D spent into that from Cambridge University when we acquired the technology. And to do that, this is much different than a phone camera. We're a class 2 medical device. Now, to be a class 2 medical device, the images below the skin and that you claim that are images that you can represent, the blood, the melanin, the dermal melanin, those chromophores, that's years of clinical studies to be able to get that out there, to be able to make that kind of representation. So that's a big barrier to entry. You can't get in there without being able to do that kind of work with that kind of contact dermoscopy. The medical clinical camera that we have, that one was designed to give perfect lighting imaging to make sure that we were able to have autofocus that went quickly so that we didn't have fuzzy images. So these were actually medical devices. So you're really, to get in this space where you're just using phones and things of that nature, that really isn't in the same ballpark as us. So that's a much bigger differentiation. And I would also say the security protocols that we put into place allows us to go enterprise wide for big companies. So the CVSs or McKesson's or, any of the, like we're in Rexall and stuff like that. And those reasons we're able to do that is because we have that kind of security system built in underneath our patient protection.
Are there any limitations to sending those images across the wide world web or whatever in terms of the amount of bandwidth required? Have you experienced any issues there?
No, it's the way that we use our own compression algorithms and things of that. We can do it quite easy. We make sure and it's asynchronous. So what we're doing is we're taking the image, storing, forwarding it. So we're able to do that. Although you bring up an interesting point, we do have dermatologists have to be registered and read the scans in the country of origin, and they have to be licensed either in the province or state or wherever it is. So we have a worldwide web of dermatologists that are there and eligible to read us wherever we're expanding into.
That brings up my second follow-up question in terms of, you talk about worldwide and you have to be licensed in particular avenues. Are the products available in the US here where I'm at? And if so, what approvals are required on the insurance front to sell the product through?
Right. So we wanted to be really careful because a lot of Canadian companies come into the U.S. and they go, it's a much more complicated market, particularly because of what you're talking about, which is the insurance codes or CPT codes, current procedural technique. We were really fortunate because we were able to recruit Dr. Dan Siegel, who was on the former American president of the American president of Academy of Dermatology, but also Dan is an expert in remuneration. So we got great guidance on what CPT codes and how to go about it. So it was nice to have Dan on our team to help us with that. So we were just starting our launching, rolling into the US market. We'll have it up on our website where people can go and get scanned. And we're in the middle of a couple pilots right now, small pilots internally to make sure we get it right. And then we'll start to expand up. But we do have some we've got some good scale projects on the go down there, but we will be putting up and populating a number of locations there shortly. And we'll have that up on our website. One of the things that we haven't done well is show people where they can go in and get scanned. So we've been working with our communication team on the web, so you'll be able to do that. But your other question, which I think is a really important one, you have to be able to have a CPT code and have it insured in the United States. And yes, we qualify for CPT codes with our technology.
Oh, wonderful. Thank you. That's helpful. Indeed helpful. You mentioned certain aspects of pilot studies or pilot programs at the end of your presentation, and then you mentioned that just now in the last part of your answer to my last question. Are these part of that pilot issues you're talking about in terms of people seeing what's transpired and what kind of progress you're making?
Yeah, we've announced a lot of the pilots after we get the MOU, but we've been careful with the pilots to make sure that they're getting structured. We've sort of taken a step back because we've had the new clinical camera to add to our to the decision tree. Okay, so one of the things is having a contact dermoscopy and everything's great, but having the clinical camera was one of the feedback we got from the dermatologist would really complete the session because that's the way they triage a patient. So we built a proper clinical camera, and now that's part of it. So now we are, the whole team on the sales team is out getting pilots underway. So we've done a way of codifying. The good thing about COVID is it allowed us to figure out how to digitize and codify our business so we could go fast. So that gave us a little bit of a breather to get that done. And I think over the next quarter, people will be surprised at the number of pilots that we start to pop out of the woodwork with. And when most of them are well on their way. And then once we get them up and running, then we'll announce that we have the pilot that's up and going, and we'll give them the scale of what it looks like.
You mentioned the AI side of the business. Are other companies doing this at this juncture or in the early stages? And if so, what makes you different from them in terms of the product offering then?
Yeah, this is one we could spend a lot of time on, Greg, but let me see if I can wrap it up yeah. Let's see if we can wrap it up in something that makes sense. So Google just announced that, and basically Google announced, send us your images and we'll tell you what we think it is. And they gave you what their AI was. But if you actually back test the AI, it's got really poor results. So, you never want to use Dr. Google when you're dealing with things that are potentially skin cancer. But they're using it to collect the metadata. And I understand that process because that metadata they can resell. Fine. In terms of people that are using AI, a lot of them, because they have really poor image quality, are trying to they're trying to jump ahead and think that AI is some sort of, it sells well, it's kind of really shiny and stuff like that, that it'll have a functional piece. And our belief system is it won't. It's not going to replace the dermatologist. And here's the big risk of it. If I say my AI can diagnose a melanoma, and I take an image and it says this is not a melanoma, and maybe it's a nodular melanoma and the AI just missed it. Now, as a company, I'm at a liability because now I'm a diagnostic company. And that's a big issue. So we never wanted to be able to think on that way. What we wanted to be able to do is say, we guarantee when we send images over to a dermatologist that that image is accessible and readable. The other secondary part of that is as we collect more and more, metadata on that, we're able to say, let's say a dermatologist writes down because this is all scripted, writes down, oh, I think that's just what we call a solar lentiga, so just something like a sunspot, and marks that. But the AI is running underneath and says, I'm not reading it as that. I'm reading that as a nodular melanoma. The AI can pop up like a wizard and say, are you sure? I think this is a nodular melanoma, just to give the dermatologist a little bit of a pause to review it again. That's all. So it acts as a gut check, if you will. And we think that has a huge amount of value to the dermatological community. So we try to think of real world environments in which we want to have it. And then we also have it where we can look at number of dermatologists, 100 dermatologists looked at a particular rash, and this was the most effective pharmacology that could be used against it. Well, we can actually run that and say, here's the pharmacology that we know works best with that rash. Those kinds of uses is where, without getting too much further along here, Greg, that's what we're working on in our stuff. And as we collect real world pictures, and one of the other things, and I'll just say this, a lot of the images that are already collected that people are using as their baseline, these are highly manipulated images. So when you put them in a real world environment, they don't work. Our images, because of the way our images perfectly fixed focal point, absolutely perfect image capture every time, we don't have the garbage in, garbage out problem. Our images are perfect every time so that they can be translated immediately into the AI. I think I'll leave it at that. You got me on a subject matter I really like. So
that's great. Please keep going if you'd like. It's fine. That's a great answer to the question. Thank you.
No, I think we covered enough on it. Thank you.
Would you say that between the image capture technology and the use of AI, this gives you a head start relative to the rest of the marketplace environment and competition? And if it does, are there other differentiators between you and other, say, teledermatology companies beyond those two key areas?
Yeah, I think we've got a huge market advantage in there now because we've been doing this for a while. And we've come out of this from the very beginning from this device was designed for dermatologists, the original scope. We've had good success by taking our scope. We did a trial with another telemedicine company before we built our own platform because we wanted to control the data. And we were in 104 Boots pharmacies in the Netherlands. Oh, sorry, in Norway, not Netherlands. Sorry, in Norway. And we were in 104 Boots, and this is a published piece of paper, 104. And we did over 80,000 scans where people just walked in, high incidence of skin cancer, walked in and got scanned over a period of 4 or 5 years, where we did our first proof of concept with the technology with the Cyscope. And of the 104 pharmacies, we did 80,000 scans. We caught 862 melanomas. So there's 862 people in Norway today that have a better existence because of this technology. And we've got a number of, non-life-threatening skin cancers like basal cells and squamous cells and that. But the one that'll get you, the melanoma, the 862 of them. So that proof of concept is we're way out there. So when we go out and people say, well, what proof do you have? We've got a lot of clinical and research peer-reviewed papers on that. So we get a lot of respect. And, we've got a number of dermatologists that we're bringing on to our medical advisory board that are world-renowned dermatologists. So, having the dermatological community, I was just down recently in Tampa to one of the dermatologists said, finally, a teledermatology company listened to us. So that was a really nice endorsement. So, we're going to just keep working for them so that we can get this deployed around the world.
Well, that begs another question that I have in terms of what kind of feedback are you getting beyond the one you just indicated from dermatologists regarding your product and the technology that they're using?
Well, the sort of older school dermatologists, like everything, are a little hesitant, and I'm older, so I get it. It's like, give me the 8 track, I can figure that out. The other one, so it's a little bit of that resistance as to the way it was. To the younger generation, they really, really are adopting this. And the reason why is because of patient care. So think of it like this. If I just looked at the Canadian model, and this is true around the world in a lot of models, people go to a GP. Now, in Canada, you have to be referred, unless you're on the public system, not the private system, you have to be referred to a dermatologist by a general practitioner. Well, the general practitioner really isn't particularly good at understanding what a melanoma is, so they send everything to the dermatologist. Now imagine you've waited 8 months and you get to the dermatologist. Now you're thinking, do I have a ticking time bomb, a cancer in me? And you get to the dermatologist, and the dermatologist looks at it and goes, called a sub-K, and goes, oh my God, I can't believe he sent me another sub-K. But it's a 15-minute block of that dermatologist's time to have a chat with you and do all of that. So that is a very time consuming and a waste of time. So where we really benefit is you can give the exact same diagnostic capability and quality of diagnostic in 30 seconds looking at our technology. So in the US market, where it makes a big difference is a lot of the aesthetic and dermatological clinics are owned by private equity funds.
Mm.
And of course, to them, it's a yield management tool. So it just depends. It's a little bespoke in every environment, but the idea behind it is let's get as many people through as we can, but let's triage them using this technology so that we can deal with the stuff, and we can get them the right dosage on their rashes and things of that nature. So that's kind of the premise, and that's why I think we're going to get we continue to get great acceptance from the community.
I hope I'm not being somewhat discriminatory in terms of the age bracketing here that you talked about, but
Right.
what is your target market? Is it younger dermatologists, private practice? I mean, where do you kind of like target your capabilities?
Well, the first part is, to get the scopes in an ease of access location. So you're looking at medical clinics and pharmacies. Employer health is a big one too. So let's say I'm a large scale employer, health provider, and I'll have maybe 1 million or 2 million patients that I'm responsible. Well, what I want to do is make sure they've got good health and they're working. So I look at it from a health economics point of view and say, boy, if that one of our employees has melanoma, boy, that's it. So we can target that, and we're doing a lot of work in that space right now. So, for example, airline pilots, twice as susceptible to skin cancer as a regular population. So we can sit there and make sure and that's a really big deal because if an airline pilot has a melanoma, that goes into the brain, and that can become quite an issue. When somebody flying a plane who all of a sudden has cancer and it could be pushing on parts of the brain to tell you that's a fluffy cloud you can land on. You don't want that kind of thing. So that's really good. So we make sure we're in one of the major airlines and that we scan their pilots and that. And interestingly enough, there's that occupational side. So to answer your question, areas where we have high access to patients. So pharmacies are used to that, med clinics are used to that. That's where the imaging scanning. The dermatologists really look at us as a yield management tool, a cash flow to them for patients. They can get through more patients, they can give quality assessments, quality of care, and then they can, because of the way the patient management system works, they can get that patient back out and they can get them into further follow on. So it works really well for them.
In terms of hitting those markets, you mentioned pharmacies. Are they able to handle that kind of assessment in terms of just finding the time or the staffing requirements?
Yeah. So we've done stuff in pharmacies. We did 80,000 scans in 104
Mhm.
pharmacies, so clearly they can do it. So a lot of the times where they have the back room, the consultation room, that's where we sit. And so what'll happen is doctors will send them in, or patients, or they're sitting there waiting for their script, and it could be 15 minutes. They'll say, oh, by the way, I've got a molar lesion, and they can just go in and be scanned. The actual time it takes for me to sit down and scan you and onboard your information from beginning to end is maybe 4 to 5 minutes. So it's that quick to go in and get your patient information down. Takes no time to get a scan, and then it's sent off to the dermatologist. We've got your patient information. You get a report and a callback that says everything's fine, or you get a call back that says, you need a consultation, and here's a dermatologist, can Tuesday work or is Thursday better? So that whole closed loop system works very well.
You mentioned the Netherlands
Yeah.
and business there, and you've adopted a razor blade model, I presume. Can you talk more about that and how that translates to other parts of the globe?
Yeah, the Netherlands was one that we had our earlier technology in there, which didn't have the telemedicine platform. And so they were working on a standalone unit, which didn't give us the kind of recurring revenue model that we had wanted. But we worked with the team over there, Paul, the leader over there, exceptional, wanted to try it. So we were able to take the technology, and we started with 4 locations. Well, they started doing 25, 30 scans a day. So it's covered under the healthcare. They did a little bit of social media and lineup started. They had 25, 30 people coming in a day. And so, that model worked out to be a very lucrative model in terms of, we were getting good assessments, we're catching melanomas. And in a short period of time, because it was a bit of a pilot slash, we're rolling, we did 4,000 scans. And like I said, we've caught 200 melanomas. Well, now they're moving it to location to location to location. In fact, our team's over in the Netherlands this coming next Sunday, and we're just looking at the expansion program over there. So yeah, that's been a successful model. And now the question is that a replicable model? Well, they also want to go into some of the other Baltic countries because of their success and their knowledge. They're moving into that. You'll see us have a very strong presence in the European theater in the next short while. We've got a number of initiatives we're starting in there, and they'll be starting very shortly. And they replicate the model in the Netherlands.
Thank you for that. The
Good.
response that you give to my questions are fantastic. Thank you so much. That's all I had at this point in time.
Oh, well, that's wonderful, Greg. Well, listen, it's been an absolute honor, and they were great questions, and thank you so much.
Thank you for joining us for this NobleCon online investor event presentation, brought to you by Channel Check and Noble Capital Markets. Visit our YouTube channel for more video content, including interviews, virtual roadshows, and conference presentation replays. New content is added regularly, so subscribe below to stay up to date. Visit channelcheck.com or click the link in the description to access equity research, news, and advanced market data on this and the 6,000 other small and microcap companies listed.